As the chairman of the prestigious Ams Trivandrum chapter, I am really proud to welcome you all to this Journal Club session. You must be knowing that we have been conducting a lot of programs for the last, say, 3.5 months. And we are just too short of our double dozen. That includes a one-day workshop on basic radiology, a national cardiac life support program, a basic pulmonology workshop, various clinical discussions, clinical case presentation, journal clubs, public awareness program, a cancer screening clinic, etc., etc. So this is yet another session of AMS chapter. I know it's going to be a very good session, very informative and very interesting session. I'm really glad to have two great academicians, Dr. Padmanabhan sir and Dr. Anju Kanmani as our coordinators. Dr. Padmanabhan sir, my senior colleague in PRS Hospital. He is the head of the Department of Pediatrics in PRS Hospital. He's a very senior pediatrician, a keen interest on academic affairs. Welcome you, sir.
Thank you.
And Dr. Anju Kanmani, probably it is his enthusiasm that is keeping this journal club going on. This is one session I don't have to do anything. I just need to come for the meeting and start talking because everything else Dr. Anju Kanmani does. And I know it's a tedious job to organize any academic session of this sort. You need to spend a lot of time, effort, talking to people and all those stuff. Thank you, Dr. Anju Kanmani.
Thank you, sir.
I'm glad to note that our president, Dr. G.S. Vijayakrishnan, has joined. I know he's very busy because today, right now, there is another session going on that is the virtual protest conducted by IMA, National IMA. That second is that draconian law that was passed in Rajasthan, right to health law. You know, that's a very stupid law that's going to affect all the medical professionals and medical institutions. Anyway, the IMA started the strike, and now today is a protest day. I know Dr. G.S. Vijayakrishnan has to participate in that. But still, he made a point to come here. Welcome you, Dr. G.S. Vijayakrishnan.
Thank you, sir. Actually,
I was not expecting. I thought you'd be very busy and you will be able to make it. And I welcome Dr. VIDHUSREE. He's going to present this very interesting article, a case. She's a junior consultant dermatologist in the General Hospital, NAIR, Trivandrum. I'm really glad to welcome you, Dr. VIDHUSREE.
Thank you, sir.
And Dr. SAJITH is a consultant physician in General Hospital, Trivandrum. He'll be the discussant. So we are expecting a very good academic feast. And I welcome all the participants, all the senior members, and my dear AMS members. Please join, try to attend almost every programs that we are conducting. That is the blessing that you can give us. And with that words, I'm concluding. I request our respected President, Dr. G.S. Vijayakrishnan, to speak a few words. Over to you, Dr. G.S. Vijayakrishnan.
Thank you, sir. Respected AMS Chairman, Dr. Pradeep, sir. Convener, Dr. Marthanda Pillai, respected senior leaders and members. Sir, Varnavale, Ireland and IMA national wide. Rajasthan Lamakariam, background law on the emergency care. Government island, private island, free to Kuduram, and the legal establishment act on the the go to the patient stabilize the patient at the hospital, Kundoanula, Saharim, and Doctor Marchedu to come on the background in law and on the day, and the doctors protested. ഭീകരമായ രീതിയിൽ ലാത്തിച്ചാർജ് ഉൾപ്പെടെയുള്ള കാര്യങ്ങൾ അവിടെ നടത്തപ്പെട്ടു. അവരെ ഐക്യദാർഢ്യം പ്രഖ്യാപിച്ചുകൊണ്ട് നാഷണൽ വൈഡ് ഒരു പ്രൊട്ടസ്റ്റ് ആയിട്ട് ആചരിക്കുകയാണ്. വിർച്വൽ പ്രൊട്ടസ്റ്റ് ആണ് നടക്കുന്നത്. അതിൻ്റെ ഒരു വിർച്വൽ മീറ്റിംഗ് പോലും ഇപ്പൊ നടക്കുന്നുണ്ട്. അപ്പൊ അതിന് പങ്കെടുക്കേണ്ട അത്യാവശ്യം തന്നെയാണ്. അതുകൊണ്ട് തന്നെയാണ് നമ്മുടെ ഇന്നത്തെ സെഷനിലെ ആൾക്കാർ കുറച്ച് പാർട്ടിസിപ്പേറ്റ് ചെയ്യേണ്ടി വന്നത് ഞാൻ മനസ്സിലാക്കുന്നു. ഏതായാലും ഇവിടെ നല്ല രീതിയിൽ AMS അക്കാഡമി മെഡിക്കൽ സ്പെഷ്യാലിസ്റ്റ് വേണ്ട ബ്രാഞ്ച് 2 days ബാക്ക് നമ്മുടെ റെസിഡൻസിയിലെ വലിയ പ്രോഗ്രാം ചെയ്തിട്ടുണ്ട്. വർക്ക്ഷോപ്പ് ആയിരുന്നു. ജാം ബാക്ക് ആയിട്ട് തന്നെ നമ്മുടെ സ്റ്റേജ് മുമ്പോട്ട് പോയിക്കൊണ്ടിരുന്നത്. അതേ രീതിയിൽ AMSന്റെ എല്ലാ പ്രോഗ്രാമും നല്ല അറ്റൻഡൻസോട് മുമ്പോട്ട് പോയിക്കൊണ്ടിരിക്കുന്നു. ഇനിയും നല്ലൊരു പ്രോഗ്രാംസ് നടക്കട്ടെ. നമ്മുടെ ജേണൽ ക്ലബ്ബ് ഡോക്ടർ പത്മനാഭ സാറിന്റെയും അതുപോലെ തന്നെ അഞ്ചു കൺവഴിയുടെ നേതൃത്വത്തിൽ നല്ല രീതിയിൽ എല്ലാ മാസവും കൃത്യമായി നടന്നു പോയിക്കൊണ്ടിരിക്കുന്നുണ്ട്. മാക്സിമം ആൾക്കാർ പാർട്ടിസിപ്പേറ്റ് ചെയ്യണം. നമുക്കൊരു ഗെയിം ചേഞ്ചർ എന്ന രീതിയിൽ നമ്മുടെ എല്ലാ ഡോക്ടർമാർക്കും അവരുടെ പ്രൊഫഷണൽ എക്സലൻസ് മുമ്പോട്ട് കൊണ്ടുവരുന്ന രീതിയിൽ അവരുടെ പ്രാക്ടീസ് അപ്ഡേറ്റിംഗ് ഗൈഡ് ലൈൻസ് ഉൾപ്പെടെയുള്ള കാര്യങ്ങൾ വർത്തിക്കൊണ്ടിരുന്ന AMS മുമ്പോട്ട് പോയിക്കൊണ്ടിരിക്കുകയാണ്. IMET വളരെ കമ്മിറ്റഡ് ആണ്. മെമ്പേഴ്സിനെ പരമാവധി അവരുടെ പ്രൊഫഷണൽ എക്സലൻസ് കൊണ്ടുവരുന്ന രീതിയിൽ IMET മുമ്പോട്ട് പോയിക്കൊണ്ടിരുന്ന എല്ലാവിധ സഹായങ്ങളും ചെയ്തുകൊണ്ടിരിക്കുന്ന പ്രതിക്കിടക്കുന്ന സാറിനും ആനന്ദ് മാത്രം പ്രത്യേകം അഭിനന്ദനങ്ങൾ രേഖപ്പെടുത്തിക്കൊണ്ട് നല്ലൊരു സെഷനും കൂടി നടക്കട്ടെ എന്ന് ആഗ്രഹിച്ചുകൊണ്ട് നിർത്തുന്നു.
Thank you, Dr. G. Sujesh. Now, our convener, Dr. Anand Marthandapilla, has also joined the session. I don't need to welcome him. He is a part of our AMS family. We work as a great team, and he'll be proposing the vote of thanks. Anyway, welcome, Dr. Anand. He's a cardiologist in Nandavuri Hospital. Now, to start the session, I request Dr. Anju Kanmani to go ahead with the academic program.
Thank you very much, sir, and glad namaskar to all. Welcome you all to this session of the Journal Club. And at the outset, I would like to say that we are all with the IMA regarding the protest that is going on. And this program was pre-charted, otherwise we would have joined the virtual meeting actually. Anyway, and today we know that today also and yesterday also in the newspaper there was issues regarding the increase in temperatures. And heat smoke and these issues. And kindly mute the other persons kindly. Thank you, madam. And so we were planning to do something which was very useful for the for the practicing doctors also, even though this is a journal club and all. So we were trying to find a good article in a recent indexed good journal with a good impact factor if possible, and which is useful for the practicing doctors also. So the research was meticulous and all, Padmanabhan sir knows, and finally we came up with something. I mean, we had a few choices and finally we fixed this journal article which deals with heat rash actually. And VIDHUSREE madam, as we all know, madam is very keen and enthusiastic in the academic programs all around the, in the Trivandrum as well as in Kerala. In many platforms like AGMA, IMA and all, madam is always doing academic classes, awareness classes, conducting camps, workshops, etc. and all. And in COVID times also, madam was very keen in doing these classes and all. And madam was also a major faculty in this monkeypox issue and all. Madam has done many workshops on dermatology, these things also. And it will be a very useful session as far as this journal club is concerned, because we are dealing with an interesting article madam has come up with. And Padmanabhan sir, as we all know, is a great academician and teacher, and sir is famous. I mean, is noted for his a strong opinion regarding the science, which has got a scientific basis and all. And regarding SAJITH sir, I mean, I have always found that this medicine people are the most, without due respect to all people, medicine people are all the most humble people in this world and all. Maybe because they see most people with all kinds of illness and emergencies and all. And I have always regarded it in that way, my teachers like Matthew Thomas or Joe Phillips sir, etc. And SAJITH sir is also one among those people who is very humble and very knowledgeable actually. And sir is with us during this COVID times doing these academic programs, giving classes and all. Sir was the major resource person in monkeypox training and all. And sir was very happy to accept the invitation for this journal club as a discussant also. And without losing any time, I would like to request Dr. VIDHUSREE Madam to share the slides and go ahead with her presentation. Before that, I would like to request Padmanabhan sir to say a few words, if has any. Usually, sir presents and
comments. I think let's go ahead with the presentation.
Yes.
I'll come late. Okay. Please go ahead with the presentation.
Madam.
Good evening to all. At the outset, I would like to thank the Ima Ams team, especially Dr. Anju Kanmani sir, for giving me an opportunity to present in front of such an elite audience. This topic, it's not something very, complex or anything. This is an atypical presentation of a seemingly innocent disease, that is miliaria, which we usually encounter and which at least once in our lifetime we all might have experienced ourselves. This is from a journal called Curious, and this is the incident happened at a tertiary care center in Bahrain in the dermatology department. So I'll just tell you about the summary of the case. This is about a 47-year-old female who had presented in the emergency department of the dermatology, not the dermatology, emergency department of the tertiary care center in Bahrain with high fever. Then she had a rash all over her body, intensely pruritic. She was a 47-year-old female, and her vitals were stable, and she was normal, except for that she had a G6PD deficiency, and she had anemia also. And during the course of her admission in the hospital, she had suffered one attack of syncope, which was corrected with IV fluids. Otherwise, she was normal. And before coming to this particular tertiary care center, she had so treatment at a local hospital where she was given, of course, IV corticosteroids and topical steroids also. So coming to the main case, a 47-year-old female known to have glucose 6-phosphate dehydrogenase deficiency, but otherwise healthy, presented in the emergency room with a 5-day history of pruritic rash, and also she had a high-grade fever. Just before this rash appeared, the pruritus was high during night, and it was told that she couldn't sleep. And upon admission, a general physical examination and laboratory testing were done, and everything was normal, except, as I had already told, the patient had anemia. On examination, the doctors could see that there were multiple vesicles and bullae on an erythematous base, mainly on the trunk, abdomen, and back, and sparing the face. No mucosal lesions were there, and when ruptured, these vesicles and bullae released clear fluid, and Nicols's sign was not appreciated, as we all have studied in our MBBS undergraduate classes. Nicols's sign means it is the shearing of the epidermis, which is seen in SJS, TEN, cephalococcal Scalzin syndrome, pemphigus especially, where the epidermis slides over the dermis and it is sheared off. So this is not, that means the pathology is within the in the dermo-epidermal junction. So that is not seen in this case. And also, Zang test was unremarkable. Zang test, as we all know, it is done in viral infections, especially in varicella, then herpes, etc., where the fluid from the vesicle or the bullae is examined, is stained like right or ginseng stain, and then we examine it under the microscope, and we can demonstrate multinucleated giant cells. This is not found in this particular lady's case. Now, cell blood count was notable for mild anemia. Then additional tests, including urinalysis, serum chemistries, vasculitic workup, were non-revealing. Serological tests for herpes simplex, varicella, blood culture, wound culture, all were within normal limits. So this is the rash. The particular thing about this is there was coexisting vesicles as well as bullae all over the body, especially over the abdomen, and on an erythematous base. Multiple erythematous dusky papules and papular vesicles were seen on the extremities, especially upper extremities, the lower extremities also. Now, the differential diagnosis at the time of admission included miliaria crystallina or rubra. then bullous pemphigoid, viral exanthems, allergic dermatitis, disseminated herpes, varicella, and vasculitis. Now, what they did was they took a 4 mm skin punch biopsy from the abdominal lesions, and there they could demonstrate focal parakeratosis, all the characteristic features of miliaria. So the histopathological evidence of vasculitis or viral infection was absent. In this picture also, this is the histopathology. You can see that there's an intraepidermal edema separating the epidermal collagen fibers. Now, while waiting for the serology, laboratory, and pathology results, the patient was initially managed with IV acyclovir because they thought that this could be due to some viral, especially varicella. Then topical steroids, cetirizine, paracetamol, cool compresses, and IV fluid supports. But over the next few days, while the patient was on this empiric and supportive therapy, she did not develop any new lesions. As I had already mentioned, she did have a single episode of hypertension, which is corrected by the adjusting the fluids. Then the diagnosis of miliaria induced by fever was made based on the clinico-pathologic correlation, her response to treatment, and the type of miliaria was considered to be an overlap between miliaria crystallina and miliaria rubra. After allergic and infectious causes were ruled out, acyclovir was discontinued as it did not find any value in this case. And the patient was treated with antihistamines, topical steroids to control pruritus, as well as oral paracetamol and compresses to cool the body and reduce the fever. So a couple of days after admission, as gradually the fever subsided, almost all the blisters, receded, and some were replaced with serous crust. But the background erythema also disappeared, and the patient was discharged without any medications. And on the first follow-up, a week later, all the previously crusted lesions healed completely. Now, discussion. Now, although miliaria, we all say it is common in newborns and infants due to the immaturity of sweat glands, it is also seen in the adults who are exposed to hot and humid environments. There are three main types. One is miliaria crystallina, then the rubra, and the profunda. Miliaria crystallina involves the eccrine ducts, which get blocked at the level of the stratum corneum. These lesions are superficial, they are self-limiting, and can easily rupture. The miliaria rubra involves the a bit more deeper level. And that is the mid-epidermis, there's blockade of the eccrine sweat ducts. So a mild inflammatory reaction will be there, and it tends to form larger vesicles, but not bullar, with an erythematous base. So these lesions are typically associated with pruritus and may form pustules. Now, profunda, which is the rarest, affects the eccrine ducts at the inside the dermis or in the deep pelvis. So it forms a non-pruritic skin-colored papules, and it is the rarest. So this particular patient's presentation with a sudden onset of pruritic fluid-filled vesicular as well as bullae on the whole of the body was consistent with miliaria crystallina and the overlap with miliaria rubra. What was unusual in this case presentation was that many of the lesions were bullae with lesions larger than 1 centimeter. So coming to the characteristic of bullae and vesicle, dermatologically we say the size is less than 1 centimeter, and when the size is more than 1 centimeter, it is known as bulla. So miliaria is described as classically as small vesicles and pustules. It is a self-limiting condition. It does not reach a size more than usually 3 millimeter. So this is almost, they say that this is the first case described where they have seen bullous lesions. So allergic reactions, vasculitis, viral exanthems, and herpetic infections can have similar picture. But they excluded all this in the differentials using the serology and other investigations. In a conclusion, miliaria with multiple bullous lesions in a healthy individual is noteworthy, and this is the first case describing the uncommon presentation of a common skin disorder, which will help the dermatologists, all the clinicians, as well as histopathologists in reaching a diagnosis when faced with a similar presentation. So through this article, the authors have tried to emphasize the importance of keeping the differential diagnosed miliaria in approaching such unsuspected cases. Now, this is the common, I've just put up a few pictures. This is the common miliaria which we see in the newborns. So erythema, like small pinpoint vesicles, which is, papules, which is self-limiting. Even without any treatment, it subsides. Now, a little bit about heat stroke, as Dr. Anju had told me, heat stroke and heat exhaustion, especially in this climate. Heat exhaustion occurs when there is profuse sweating. That's what I've learned, profuse sweating, and that causes, excessive dehydration in the body. And it's actually mild when compared with heat stroke. Severe heat exhaustion can turn to heat stroke. So this the heat stroke, it presents with delirium. The body temperature, if it is above 103 degrees degree Fahrenheit or 40 degrees, there's a red hot dry skin. Sweating is absent in this patient. Then there will be rapid and strong pulse, and the patient may lose consciousness. Seizures may be there. Then the treatment is almost that is, you have to take the patient to a cooler climate, preferably in an air-conditioned place. But the since heat stroke is a bit more, a dangerous situation, the treatment should be meticulously. You have to give IV fluids, the supportive measures, everything. The other thing, heat exhaustion is a bit milder. This is what I've already mentioned. So that's in short. Thank you for your patient listening.
Thank you, madam, for that crisp presentation, Dar. So maybe we have to discuss a little more regarding malaria, like because, madam, is this malaria very common during the heat? I mean, can we stop this screen sharing, madam? Yeah, thanks, madam. So Padmanabh sir was actually telling that actually in journal clubs and all, when the problem with the personal short cases, it becomes very short, so that the time usually lapse and there won't be any. But I think a few things was very peculiar about this presentation in this case and all. The one thing is regarding this malaria. I mean, was there a history of exposure to heat in this patient as such? Because that was the history. No, madam, is it like that?
High-grade fever was there.
Okay, fine. So could be, what are the common dermatological manifestations of, I mean, exposure to heat? Can it be present, like what types of rashes can occur? Things like that.
The commonest which we see. That is the
I mean,
in our settings, sir. Do you mean in our settings?
Yeah, our settings in general.
I have not seen heat stroke personally, sir. I have not seen any patients, but malaria is common nowadays. Not nowadays, with any climate you can get in the laborers and all, manual laborers, they get this. And the neonates, it's very common, as you know, sir. You're a pediatrician, so you know that.
Yeah.
And the other conditions, the infections like dermatophytosis, these all are more common during the hotter, humid climates, especially in our country.
Okay, is it, I mean, can it occur, I mean, malaria, can it occur as a part of this exposure to heat and all, like things, can also happen?
Yes, sir. Like while we were having that COVID duty and all, many had this so-called rash. It's common, like after the PPE kit wearing and all, when you sweat so much profusely.
One question I had was that regarding this pemphigus and this malaria and all. It was very interesting to note that this was the first case in which these vesicles are being described, no?
So not vesicles, vesicles and bullae.
Now, how do you differentiate between this pemphigus and this malaria? I mean, is it the size of the bullae, or do we have other criteria to differentiate between the?
Okay, clinically we can differentiate. In pemphigus, the mucosal involvement will be there, the oral lesions. I mean, first, the oral lesions may be the first presentation in certain patients. Gentle lesions may be there. In this particular case, malaria, that doesn't affect that, sir. Then usually the face is spared in malaria. Here also the patient had extensive lesions over the trunk, the upper limbs, but face was typically spared. Then no involvement of the palms. Whereas pemphigus, you get extensive lesions, the scalp, everywhere you can get even the conjunctiva can get involved. Then the other signs, as I've told, so like they're not pathognomonic, but Nichols sign can be positive. Then systemic symptoms may be there. Usually, as I've told, sir, malaria is self-limiting. What we usually see in our clinical practice. Pemphigus, the patient may be toxic, having other symptoms. Then secondary bacterial infection. Infection is one major thing which we have to take into account when dealing with patients with pemphigus. Then the biopsy and the yes, sir.
Infection in the sense of supra-adult infection, or
yes, sir, because the skin is being sheared off, So.
So, as a part of management, do you give antibiotics, and how do you manage such a case, basically?
Where's the pemphigus?
No. First, we will talk about malaria.
Malaria, okay. Malaria, I have not seen such bullae cases, sir. I've seen malaria crystallina and the other thing. Crystallina, while I was doing my PG, that was a typical case because we don't usually see that. Like the vesicles.
Like, if it is self-limiting and all, do we really give some emollients or things like that?
Yes, sir. The point is, it is self-limiting, but patient may report with intense pruritus. Then, if it is a vesicle, they get confused with chickenpox and all. So ideally, we have to give treatment also. Like we give soothing agents, and even mild corticosteroids can be given. Then antihistamines.
That is another question I was asking, because they have given topical corticosteroids in this patient, no?
Yeah,
But
yes.
we usually, in chickenpox and all, we usually give topical only in, eye involvement or things like that. Only we usually do not give topical steroids, right? In chickenpox and all. So in malaria, do you give topical? Is it safe to give topical steroids also?
Yeah, mild steroids can be given. So in some cases, usually we give calamine lotion or soothing lotions. That is enough. And antihistamines. But if it's severe, the patient doesn't have any, symptom relief, then we'll give mild steroids.
Instantly, can you just elaborate on mild steroids? Types. Can you just?
Milds are desanide is there. Then hydrocortisone is there. Clobetasone is there. These are all mild. But these may not be necessary in most of the cases. Even with calamine lotion and the antihistamines, then bathing in cold water, you can give even an antibacterial soap for the patient satisfaction. Actually,
What about which are the stronger? Which are the other types of steroids, like potent steroids, right? Things like that. Now, how do you classify those? I still remember that classification. Can I just because we'll be using
into types 1 to 4, sir, based on the vasoconstrictive activity. Different textbooks have different classifications. First one, hypotense, you give like halobetasol, clobetasol, then even betamethasone dipropionate is potent. This changes, sir. There's not a definite classification, because with the adding of a vehicle, as well as if it is combined, like betamethasone valerate is mid-potent, or you can see mildly potent, whereas betamethasone dipropionate is more potent. So that happens, sir. Then the ointments are more potent than creams.
Last question, last doubt I have. And you usually tell this colloquial language, we tell chudu guruna. This is usually mother tells. So what exactly do we do that for that? Because that is very common in pediatric, this thing.
That's the miliaria, sir. For children, neonates, we give only calamine lotion, sir.
Okay, sorry for taking out my curiosity on this dermatological this thing and that. Because even though, as Madam has correctly told, that it could be manifestation in all types of seasons and all, but I think we should be discussing a little more about this issues. Manifestations of increased temperature in the environment, like in the form of heat exhaustion and heat stroke and all. Thank you very much, Dr. VIDHUSREE, for that excellent and crisp presentation. And Padmanabhan sir, shall we hear from SAJITH sir, or sir want to give some comment right now, sir? Padmanabhan sir.
Well, if you want me to give the comments, I can do it now. Few points here. This patient is from Manama. I think it is Manama means Bahrain. They are from the Gulf. Therefore, one point that was raised was the patient has G6PD.
Yeah.
Well, G6PD is very prevalent in the Gulf countries, about 30–40%. But what is surprising is it is a female. It's a sex-linked recessive.
X-linked recessive.
But still, you have a female patient with G6PD. And then we passed off by just telling that the patient had a syncope, nothing but a syncope, and he had a hypotension. That's very significant in this. Probably she had a heat exhaustion. In the Gulf, when you go out, you have heat exhaustion very often. It has to be taken very seriously. Anyway, that is one thing. When we are told, whenever there is a vesicle with an erythematous base, we straight away diagnose chickenpox. That's a usual thing. And the only reason why probably they didn't think about it is the patient is an older patient, or probably there was a past history of varicella. That is not mentioned in this, whether there's a fact. If I had seen the child with this, I would have straight away diagnosed it as varicella. Now, in pediatrics, we come about milia very often. That sometimes we see even in the face, we have Miliaria crystallina, Miliaria rubra, erythema toxicum, etc. The million-dollar question is it infected? Many things look pustules like something, the vesicles are there, some of them look pustules, and you have a tendency to give put topical antibiotics, which you should resist as much as possible. Now, The other thing is, I don't understand why these people went ahead with the biopsy, because it was a tertiary care center. If the biopsy was not done, it would never have been diagnosed as a miliaria, I think, in this patient. And I wonder if any of the tertiary care hospitals in our place, we would have done a biopsy. Would you have done it in a patient who comes with a vesicular lesion with an erythematous base? I have my doubt about it. Now, finally, this erythema toxicum is something which we see very often in newborns and patients. Many times the question is there a infection or not? It's difficult to make out. We send it to a dermatologist. Many of them write topical antibiotics, which we resist in newborn period. Now, a word or two about heat exhaustion and heat stroke. Now, I keep telling the people, I keep telling my postgraduates in PRS as well as wherever I studied in the Gulf also, many times, if you ask the people at the height of 50-degree temperature outside, how many heat strokes did you see? They will just say nothing. The reason is probably you are missing. The reason is the patient, when it comes with you with exhausted, you will say he's dehydrated, give him IV fluid, heat exhaustion, he usually recovers. But surprisingly, I found that in your chart which you showed heat exhaustion, low volume pulse, tachycardia, while the heat stroke, you showed high volume pulse and a good BP. I don't know why it was like that. Now, heat stroke is when you have cerebral obtundation. Many people have the feeling that absence of sweat is a very important thing. It may not be. It may not be. Now, regarding the problem of temperature, there is a problem here. The core temperature has to be measured. And the only way you can measure the core temperature is by looking at the rectal temperature. Therefore, as often we have been told, history is the most important. What you get a patient unconscious, throws a convulsion, suddenly comes to you, you might think it is encephalitis or a seizure or anything and treat him like that. And therefore, unless you, in this climate, in this place, every doctor in the periphery, not the dermatologist, in emergency also, has a clear thinking that I must consider heat stroke and heat exhaustion, you are likely to miss it. Now, regarding Nanju was asking about topical steroids and topical antibiotics, we try to avoid it as much as possible in children, but I was surprised that it is given. They are telling especially erythema toxicum, the erythema rubra especially, there'll be itching and there'll be sometimes some amount of irritation, and sometimes to differentiate whether the erythematous skin is infected or not, and therefore you might even apply low dose antibiotics. But generally, emollients, cooling, cotton cloth is the important thing. And when child comes with heat stroke, instead of dipping, you, of course, you give what you call as ice packs in the, you keep it in the groin, you keep it in the axilla, etc. On the top of it, they say you can put tepid sponging on the patient and put a fan by the side. Not cold water, because if you put cold water, he might start shivering, which will have the opposite effect. And if he starts shivering, you can give him diazepam or lorazepam, because that shivering is something you should avoid because the temperature will go up again. So these are the few points, the practical points which I thought should be important. And if you have a patient with a rash and you suspect heat rash, and the child is febrile as it and has a history of syncope, definitely heat exhaustion was probably also present in this patient. Thank you.
Thank you so much for that elaborate presentation and the great effort that Sarah has taken. Sarah has thrown light to all the aspects of that article assets. And regarding heat rash and heat exhaustion and heat stroke and all, we have an expert right here from the medicine, none other than Dr. Sajith VS sir. Sir has been listening to us regarding the case presentation, regarding the article, and as well as the the discussion and all. So now request Dr. Sajith sir to offer his valuable opinion regarding the discussion and enlighten us on this heat exhaustion, heat stroke part also. Over to Sajith sir.
Thank you, Anjisa, for the kind introduction, and good evening, dear friends and respected colleagues. And actually, there was some problem with my computer and all, and please excuse me. And the topic presentation was excellent, and it was very well discussed. And now my top duty is just to conclude the session with some slides and all. Sir, can I share?
Sure,
the
sir.
screen? Because host disabled participant screen sharing.
Just okay. Pradeep sir, can you help me right here? Can you ask IMA the host to make Sajith sir to host also or co-host? Dr. Sajith VS ആണ് co-host ആക്കേണ്ടത്. Dr. Sajith VS. Okay. Thank you, sir.
Full screen ആണോ സാറ്?
അല്ല സാറ് സാറ് മെയിലാണ് തുറന്നത്.
മെയിലാണോ?
അല്ല അത് കുഴപ്പമില്ല, അത് ഫുൾ സ്ക്രീൻ ആക്കിയാലും അത്.
ഹലോ
ആ സാർ കേൾക്കാം, കുഴപ്പമില്ല. പക്ഷെ എനിക്ക് തോന്നുന്നു മെയിലാണ് തുറന്നിരിക്കുന്നത്. സാറ് അതൊരു മൂവ് ചെയ്ത് പറഞ്ഞു തുടങ്ങുന്ന തുടങ്ങിക്കോളൂ. അത് മൂവ് ചെയ്ത് നോക്കാമോ സാറേ? സ്ലൈഡ്
മൂവ് ചെയ്യുന്നുണ്ടോ?
ഇല്ല. മീൻവെയിൽ സാർ ഇപ്പൊ വന്നായിരുന്നേ. മീൻവെയിൽ സാർ ഇസ്
ഇപ്പൊ ചെയ്യുന്നുണ്ടോ?
ഓക്കെ, ഇപ്പൊ കറക്റ്റ് ആണ് സാറേ. മൂവ് ചെയ്ത് നോക്കാം സാറേ സ്ലൈഡ്. ഓക്കെ, പെർഫെക്റ്റ് ആണ്. പ്ലീസ് കണ്ടിന്യൂ.
Okay. So today's a short discussion on heat stroke. So we all know about the burns and the complications of burn and the percentage of burn and the prognosis and the mortality in case of burns. Heat stroke is one thing which is almost similar to a heat stroke. Here we can see that, just consider this as our border, and our skin is our border, and this is our soldiers, and these are our body defense mechanism. So what actually here happens in a burn is this defense, that is, this border is disrupted. But in heat stroke, what happens actually, there is no that much disruption of this border. What happens is that മതിലിനകത്തൂടി ചൂട് കാറ്റ് ഉള്ളിനകത്ത് കയറുക ചെയ്യുന്നത്. That is what's called a heat stroke. And what happens to the defense mechanism is exactly what is happening in heat stroke. And there are so many terminologies there. What is called heat wave. Heat wave means 3 or more consecutive days during which the air temperature is more than 32.2 degrees centigrade. Then next terminology is heat stress. Stress means it's a perceived discomfort and physiological strain associated with exposure to a hot environment, especially during physical work that we all experience. Then coming to the heat stroke, here a severe illness. So it is a severe illness characterized by a core temperature more than 40 degree. As Paramana sir already discussed, what is the core temperature? It's actually a rectal temperature more than 40 degree or 103 degree Fahrenheit, and plus a central nervous system abnormality, such as it should be there for the heat stroke, delirium, convulsion, or coma resulting from exposure to environmental heat, classical heat stroke, or from a strenuous physical exercise. It is called exertional heat stroke. So actually, there are two types of heat stroke are there. One is the classical heat stroke, and the other it's called exertional heat stroke. Exertional heat stroke severe exercise ചെയ്യുന്ന യങ്സ്റ്റേഴ്സിന് യൂഷ്വലി കാണുന്നതാണ്, എസ്പെഷ്യലി വെൻ ഗോയിങ് ഹോട്ട് ഹ്യൂമിഡ് ക്ലൈമറ്റിൽ ജിമ്മിലൊക്കെ പോയി ഓവർ എക്സേർട്ട് ചെയ്യുന്ന പേഷ്യൻസിനെ കാണുന്നതാണ് exertional heat stroke. The other one is a classical heat stroke which occurs in a climate like this. Then a heat exhaustion, it's a less means severe illness. It is mild to moderate illness due to water or salt depletion that result from exposure to high environment heat or strenuous physical exercise. Then signs and symptoms include intense thirst, weakness, discomfort, anxiety, dizziness, fainting, headache, and core temperature may be normal, below normal or slightly elevated, more than 37 degree, but it is always less than 40 degree. Once it crosses the core temperature cross 40 degree, then a diagnosis of heat stroke can be made. Then hyperthermia is there, a rise in body temperature above the hypothalamic set point, where the heat dissipating mechanism are impaired, especially when those on certain drugs or on certain disease or overwhelmed by external environment or induced. Then internal metabolic heat and also. Then finally, multi-organ dysfunction that may be the cause for the death in case of a heat stroke. Some FAQs about extremely heat. The same definition in another slide. Here, what happens? What's the pathology there? What's happening? Here we can there in case of heat stroke, two things are. First, initial phases are compensated phases, and the others uncompensated phase. What happens then? Initially what happens that a metabolic rate increases, then core temperature increases, cardiac output increases, and skin blood flow increases, and visceral blood flow also it decreases. So that visceral blood flow that will be directed to the skin, and we will sweat. That is a compensating mechanism after sweating. After as a result of sweating, it's a mechanism to cool our body. And what happens later? The CVP comes down, then core temperature increases further, then resulting in a circulatory collapse. Then intestinal permeability increases, then energy depletion, resulting in cell anoxia. Then endotoxins will be released. Then core temperature when increases further, then inflammatory reaction occur, and blood-brain barrier breakdown occurs, and CNS dysfunction and global encephalopathy occurs. And it is called that syndrome is called a heat stroke. And finally, if it is not treated or adequately treated in time, the patient, we will lose the patient. So other thing happening is the liver, all the organism will sustain the effect of this heat. There is liver dysfunction, acute renal failure, coagulopathy, DIC, then muscle breakdown, and cardiac dysfunction. Actually, heat stroke, at least we should know all this. That is core temperature more than 40 degree or 104 degree with the central nervous system dysfunction and systemic inflammatory response, and resulting in DIC, then heart dysfunction, rhabdomyolysis, pulmonary edema, liver failure, and renal failure. So that patient should be promptly diagnosed and treated in the ICU. Otherwise, we'll lose the patient. This slide already discussed by Dr. VIDHUSREE, and these are some FAQs that what happens to the body when exposed to extreme heat. And we know people suffer heat-related illness when the body temperature controlling system is overloaded, and body normally cools itself by sweating. But under some condition, sweating is just not enough. So in that case, in such cases, a person body temperature rises rapidly. And when very high body temperature may result in damage to brain and other organs, then several factors affecting the body's ability to cool itself during extreme hot weather. When the humidity is high, sweat will not evaporate. That's the most important thing. When the humidity is high, sweat will not evaporate as quickly and prevent the body from releasing heat quickly. Then other condition, there is a individual condition that may limit the ability to regulate temperature, include old age, elderly patients. The old age their immune defense mechanism will be less. Then young, 0 to 4 years, then the patient is having obese patient, fever, dehydration, those with the heart disease, mental illness, then poor circulation, sunburn, or certain drug, and the most important thing is alcohol use also. And who are at greatest risk for heat-related illness include, as already discussed, infants and children, and up to 4 years of age, people more than 65 years of age and elderly, and who are obese, and people who are ill and on other certain medications. Heat stroke, once again, is a most serious heat-related illness. We have discussed so many heat-related. This is the most serious form. It occurs when the body becomes unable to control its temperature. Body temperature rises rapidly, sweating mechanism fails, and the body is unable to cool down. And body temperature may rise to 106 or higher within 10 to 15 minutes, and can cause death or permanent disability if emergency treatment is not provided. And what are the warning signs? Again, extreme core temperature more than 103 degree Fahrenheit. Here, red, hot, and dry skin, no city. Sweating, rapid and strong pulse, then throbbing headache, dizziness, nausea, confusion, and unconsciousness. And what should I do if I see someone with any of these warning signs or hot stroke? Then we have to, it's an emergency. So we have to deal, it's a life-threatening emergency. So emergency, we have to shift the patient to the ICU. We have to arrange the ambulance. Till the ambulance come, we can get the victim to a shady area, then cool the victim rapidly with whatever methods you can. For example, immerse the victim in a tub of cool water. Place the person in a cool shower. You can spray the victim with the cold water from a garden hose, or sponge the person with the cool water, or if the humidity is low, wrap the victim in a cool wet sheet and fan him or her vigorously. And monitor temperature and continue cooling effect until the body temperature drops to 102, 101 or 102 degree Fahrenheit. And if emergency personnel delayed, the patient can be shifted to the emergency room. And most importantly, do not give the victim alcohol to drink, and get assistance as soon as possible. And heat exhaustion, we have discussed, is a milder form of heat-related illness. And here also, elderly population and those with high BP and those working or exercising in a hot environment are more prone. Here also, the warning signs are almost the same, but here we can see that there is profuse or heavy sweating is there. Then paleness, muscle cramps, tiredness, weakness, dizziness, headache, nausea, vomiting, faintness, and skin may be cool or moist. Pulse rate will be fast and weak, and breathing will be fast and shallow. If exhaustion is untreated, it may progress to heat stroke. So timely management is very important. And the steps which can be taken to cool the body during heat exhaustion, again, ask the patient to drink cool, non-alcoholic beverages, rest, take a cool shower bath or sponge bath, then seek an air-conditioned environment, then wear lightweight clothing. Then heat cramps. Here, heat cramps means just like a cramp, so muscle pain or spasm, which is usually in the abdomen, arms, or legs, which usually occurs in association with a strenuous activity. People who sweat a lot during strenuous activity are prone to heat cramps. This sweating depletes the body's salt and moisture, and low salt level in the muscle cause painful cramps, and heat cramps may also be a symptom of heat exhaustion. Then in that case, if the patient doesn't have any heart disease, we can provide them a low sodium diet. Here, what are the patients having heat cramp? We should stop all activities, drink clear juice or sports beverage. Then do not return to strenuous activity for a few hours after the cramps subside, because of further exertion may lead to heat exhaustion or heat stroke. Then heat rash, already discussed, skin irritation by the excessive sweating in hot climate, hot humid climate, It can occur at any age, but as discussed, are more common in young children. Then certain medication, that's very important to increase the risk of heat-related illness. And most common is a psychotropic drugs which affect psychic function, that is, and behavior. Then haloperidol or chlorpromazine. Then drugs for Parkinson's that may inhibit perspiration. Then tranquilizers, that phenothiazines, butrafenones, and thiazines. Then diuretics or water pills that affect fluid balance in the body. So we have to be more cautious when the patient is on these drugs. Then what about how effective are the cooling mechanism? Then electric fans, it can provide comfort, but when the temperature is in the high 90s, fan will not prevent heat related illness. So ideally taking a cool shower or bath or moving to an AC place is a much better way to cool off. Then AC is the strongest protective factor against heat related illness, and exposure to air conditioning for even a few hours a day will reduce the risk of heat related illness. And consider visiting shopping malls or public library, or we can even in the ATM like that will be useful. And drink plenty of fluids, replace salt and minerals, wear appropriate clothing, sunscreen, then cool indoors. These are the various methods to prevent. Then this is the difference between a classical heat stroke and exertional heat stroke. Exertional means it occurs in a sporadic, because it occurs at any time of the year after a strenuous activity and excess heat production, which overwhelms heat loss mechanisms. And CNS dysfunction is common in both the condition, and we can see that acid-base balance, respiratory alkalosis is common in a classic heat stroke than exertional heat stroke, which is maybe a metabolic acidosis. And the method of cooling already discussed. And this is the importance of cooling. If the cooling is delayed, severe hepatic dysfunction, renal failure, DIC, and fulminant multi-organ dysfunction can occur. Then hepatocytes are very heat sensitive. Once presentation, the serum level of AST and ALT should be monitored. And if it is more than 100 times the normal limit, we should be more cautious. And coagulation study is also very important. We demonstrate decreased platelet count, fibrogen, and PT. Most patients with this classical heat stroke require cautious crystalloid resuscitation and electrolyte monitoring, and we have to put in a CVP measurement, and we have to correct this. And prevention, to prevent dehydration, drink cold water, fluid, and adequate juices. Wear light dress and tight dress. Then cover head with a handkerchief, piece of cloth, or a hat. Then first aid, move the patient to a cool place, shady area, remove unnecessary clothes. Then keep the patient in a well ventilated area. Draw water on patient or body with the towel. Push. Then keep the ice pack between armpits, groin, and around neck. Thank you for patient listening.
Thank you, sir, for that elaborate presentation on management of heat stroke, heat extraction, and sort of things like that, actually. And in this time, it would be very appropriate, because all of us may be seeing cases more and more in the OP in the coming days and more sensitization will also be there. But it is always prudent to have this in mind while taking the history examination, and also we should be knowing something about the management and also the prevention. Can you please stop the screen share, sir? Is Vidhu madam here?
Yeah, yes, sir.
Madam, one question is there. There are a lot of OTC products in the market for miliaria. Your comment on that?
Yeah, OTC products are usually the prickly heat powders, right, sir? Those
Yeah.
are, we don't usually prescribe them, sir. Usually
Not
not preferred.
okay.
Why?
Because sometimes, already blocked sweat ducts, they form a paste over the skin with excessive sweating and all. They block, that's what some say. So we don't usually give them.
Emollients are okay, emollients.
I mean, lotions or lighter emollients, sir. Not very thick ointments, not necessary. Sir.
Okay.
Okay. There are no other questions, I think, and I think it is almost time. So I would like to request Pradeep Kidangur sir to manage the rest of the session.
Thank you. I don't know whether I think Dr. Anand has had to go back to hospital as he's on call today. So is Anand has joined or is that? I think he's not there on the list. Okay. Anyway, thank you. Thank you so much for Dr. VIDHUSREE and Dr. Sajith for that presentation and discussion. And as usual, Dr. Padmanabhan sir for that very elaborate discussion on the topic. And Anju Kanmani for organizing this. And thank you, Dr. Vijaykrishnan. I think Vijaykrishnan also has left.
Even though this presentation was regarding this article and it was a short case presentation, I wanted a bit of discussion about this
heat stroke. Yeah, I could make out. I could, and there because we are probably this is the first discussion that's going on heat stroke. No heat stroke. And no other academic body has discussed heat stroke so far in Cape Trivandrum.
I think in the coming days more discussions will come actually.
Yeah. So
actually, one question we had to ask ourselves is why are we not diagnosing heat stroke? The temperature, I mean, as the temperature rises above the body temperature or surface, then we should be getting heat exhaustion and stroke. But that is a diagnosis when you look into the hospital records, you will hardly find being recorded. And if you ask the ER doctors, do you see heat stroke or heat exhaustion? They will say, no, we don't see. Are we not diagnosing it? That's what. Do we have a method of taking the rectal thermometer? Actually, the digital thermometer, which is present, if you read the paper coming with it, it says you can take rectal temperature with that. And maybe you should have a separate thermometer in every ER for measuring patients who come with abnormal convulsions and abnormal behavior, sudden onset, and then only you will start diagnosing heat stroke. That's what I feel.
Yeah, that's a good suggestion. So even some of the digital thermometers, they have that probe cover as well. So we can use some of these digital thermometers for rectal thermometer, but I don't know how accurate the digital thermometers.
But sir, cannot we use the calculation from the axillary temperature to determine the core temperature?
No, you should use the, I think, see the point is that the axillary, the temperature outside during a heat stroke because of vasoconstriction and other reasons may be very low, considering what the core temperature is. Therefore, you cannot make that calculation in an abnormal situation like heat stroke. We have to take the core temperature. I mean, what I find is I have never seen anybody calling me and saying, we have a child with 105-degree temperature, it's a heat stroke. No. If a patient has 104, 105 and the child has a shock, invariably the pediatrician diagnose it as septic shock. If the patient has a convulsion, we will diagnose it as a seizure disorder. If the patient has an alteration in the sensorium, we would think of poisoning or encephalitis. But somehow or some reason, heat stroke never crosses the mind.
But sir, there is one issue that for a heat stroke to occur, actually, the patient should be exposed to this heat for at least some amount of time. Is it not so, Dr. Sajith, sir, actually? I mean,
30 to 45 minutes, 30 to 45 minutes is enough.
That's very important because a clinical scenario. But to take the clinical scenario, so suppose a patient is a software engineer working in a AC environment present with the similar, we have to take consider heat stroke as a differential diagnosis with a low in the list, and we have to get the DDs. High in the list is so many other things such as septicemia. Suppose a patient is a manual labor working in a part of the work it comes with, then that should be the differential diagnosis. That should be very high in the list.
Maybe the mother may be carrying the child also with her, so that, I mean, as a part of the
clinical scenario is very important. We should not miss കുറെ പേര് എടുത്തുകൊണ്ട് വരുന്ന ആ ഒരു ഇതുണ്ടല്ലോ. അപ്പൊ ജോലി ചെയ്തുകൊണ്ടിരുന്ന സമയത്ത് അവിടെ നിന്ന് കുഴഞ്ഞു വീണു എന്ന് പറഞ്ഞ് എടുത്തുകൊണ്ടിരുന്ന സീൻ. യൂഷ്വലി നമുക്ക്
സാർ അങ്ങനെയുള്ള കേസസ് ECG മാൻഡേറ്ററി ആണോ?
വെരി ഇമ്പോർട്ടൻറ്റ് അർമിയസ് വരും.
ആണല്ലോ. ലൈക്ക് ഫസ്റ്റ് എയ്ഡ് ഉടനെ നമ്മൾ ചെയ്യാവുന്ന ലൈക്ക് ഈ ഹീറ്റ് പലരും പല കാര്യങ്ങളാണ് ചെയ്യുന്നത്. ഈ പറഞ്ഞ ടെപ്പിഡ് സ്പോഞ്ച് വന്നിട്ട് തോർത്തിലിടുന്നു, അല്ലെങ്കിൽ വെള്ളം ദേഹത്ത് ഉപയോഗിക്കുന്നത്. ഐഡിയലി നമ്മളത് പെട്ടെന്ന് ഒരു ഫസ്റ്റ് എയ്ഡ് പോലെ അല്ലെങ്കിൽ എമർജൻസി ആയിട്ടോ നമ്മൾ എമർജൻസി കെയർ ആയിട്ടോ ഉടനെ നമ്മൾ ചെയ്യേണ്ടത് സാർ ഈ പറഞ്ഞ മാതിരി എന്തായിരിക്കണം? നമ്മളൊരു
അല്ല, യൂഷ്വലി കണ്ടിട്ട് നമ്മൾ ഐസ് കിട്ടുകയാണെങ്കിൽ ഐസ് തന്നെ പാക്ക് വെച്ച് ബോഡി ടെമ്പറേച്ചർ തണുപ്പിക്കുക എന്നുള്ളതാണ് ഫസ്റ്റ് ഇമ്പോർട്ടൻറ്റ്. നമ്മളൊരു 104 എന്നുള്ളത് ഒരു 101 102 കൊണ്ടുവന്ന് ബോഡി ടെമ്പറേച്ചർ തണുപ്പിക്കുക മാത്രമല്ല, അത് തണുപ്പിച്ച് കഴിഞ്ഞാൽ കുറച്ച് ബോഡി പിന്നെ റൈസ് ചെയ്യും. അപ്പൊ അത് ഈ അനദർ കെയർ കിട്ടുന്നതുവരെ നമ്മൾ ട്രൈ ടു മെയിൻറ്റെയിൻ ദ ടെമ്പറേച്ചർ. വൺസ് ഹോസ്പിറ്റലിൽ എത്തിക്കഴിഞ്ഞാൽ വിൽ അസസ് ദ സർക്കുലേറ്ററി BP വൈറ്റൽസ് സ്റ്റേബിൾ ഉണ്ടോ നോക്കും. അല്ലെങ്കിൽ പറ്റുന്നില്ലെങ്കിൽ CVP ഇട്ട് ഫ്ലൂയിഡ് റെസിസ്റ്റേറ്റ് ചെയ്യും, ആന്റി കൺവൾസൻസ് കൊടുക്കണം, ICU ബാക്കിയുള്ള എല്ലാം മോണിറ്ററിങ് അല്ലെങ്കിൽ മാനേജ്മെന്റ് വിൽ ബി ലൈക്ക് ഒരു സിവിയർ ബേൺസ് വിത്ത് ആ ഒരു സെപ്റ്റിസീമിയയിലേക്ക് പോകുന്ന അതിലേക്കുള്ള മാനേജ്മെന്റിലേക്ക് കൊണ്ടുപോകേണ്ടി വരും.
IV ഫ്ലൂയിഡ് നമ്മളിപ്പോ സപ്പോസ് നമ്മുടെ പേഷ്യന്റ് ഒരു ഹൈപ്പർ ടെൻഷൻ ഇല്ല എന്നുണ്ടെങ്കിൽ നമ്മൾ സ്റ്റാർട്ട് ചെയ്യേണ്ടതാണോ?
CVP ഇട്ടിട്ട് നോക്കാം സാർ. ഭയങ്കരമായിട്ട് ഫ്ലൂയിഡ് ലോസ് ഒരുപാട് പോയിട്ടുണ്ടെങ്കിൽ എമർജൻസി ICU ബിഫോർ ഡെത്ത് അല്ലേ?
Even the IV fluids in heat stroke is not only for dehydration. It is to give something cooling also. It is also for cooling. Because you have to give exactly I don't remember, but you are giving it for in room temperature. You are giving it so that the internal temperature also comes down. That there is another reason why you are giving IV fluids.
സർ ഫാനിനെ കുറിച്ച് പറഞ്ഞത് നമ്മൾ യൂസ് ചെയ്യാം. ഐ മീൻ അറ്റ് ദി എൻഡ് ഓഫ് ദി ഡേ നമുക്ക് യൂസ് ചെയ്യാം.
അല്ല, നോട്ട് ഹീറ്റ് സ്ട്രോക്ക് അല്ല, മറ്റുള്ള ആ ഹീറ്റ് എക്സ്പോഷൻ മറ്റേ ആ ഒരു അതിന് മുന്നിലുള്ള സ്റ്റേജസിലാണ് കാറ്റ് കൊണ്ടുവച്ച് സ്വെറ്റ് ചെയ്യണം. സ്വെറ്റ് ചെയ്താലേ അത് ഇവോപ്പറേറ്റ് ചെയ്ത് പോകത്തുള്ളൂ. സ്വെറ്റ് ചെയ്ത പേഷ്യന്റ് ഫാൻ കൊണ്ടുവച്ചിട്ട് കാര്യമില്ല. ഫാൻ കൊണ്ടുവച്ചിട്ട് സ്വെറ്റ് ചെയ്യുന്നതിന് പെട്ടെന്ന് ഇവോപ്പറേറ്റ് ഹെൽപ്പ് ചെയ്ത് കൊടുക്കുന്നതാണ്. അതർ പേഷ്യന്റ് AC തന്നെ ആയിരിക്കണം. ഇത് ബാക്കി കുറച്ച് ഒരു 10-40 സ്ലൈഡ് ഉണ്ടായിരുന്നു സാർ. ഞാനത് ടാങ്ക് കഴിഞ്ഞ് ഡിസ്കഷൻ വരാനേ കാണിക്കാൻ വിചാരിച്ചു. മറ്റുള്ള ഒരു 10-15 സ്ലൈഡ്സ് മതി എന്ന് പറയുകൊണ്ടാണ്. ജസ്റ്റ് ഒരു എവറിത്തിങ് ഈസ് ഹിയർ ബിക്കോസ് ഇൻ ദ സെയിം പ്രസന്റേഷൻ ഓൾസോ ആഫ്റ്റർ താങ്ക് യു 30-40 slide explaining everything, what is DC, how it happening, what is happening inside our body, everything is in that slide set itself. Thank you. കഴിഞ്ഞ് 2 സ്ലൈഡ് കഴിഞ്ഞ് ബാക്കിയെല്ലാം ഇട്ടിട്ടുണ്ട്.
ഒരു മിനിറ്റ്, ഞാൻ പത്മനാഭൻ സാർ പറഞ്ഞ പോയിന്റ് ഇസ് വെരി ഇമ്പോർട്ടന്റ്. സോ ആർ വി യൂസിങ് റെക്ടൽ ടെമ്പറേച്ചർ?
ഇല്ല സാർ, ഇല്ല. നമ്മൾ ക്ലിനിക്കൽ സിനാരിയോ വെച്ച് ഇത് വെച്ചിട്ട് മേ ബി അല്ലെങ്കിൽ ഹൈ ഇൻ ദ ലിസ്റ്റ് എന്നുള്ള വെച്ച് നോക്കിയിട്ട് മാത്രമേ ചെയ്യത്തുള്ളൂ.
അല്ല, ഒരു കാര്യം ഈ ഹീറ്റ് സ്ട്രോക്കിനെ പറ്റി
അല്ല സാർ, ചില വേറെ കാര്യം ചില ബാക്കി വെദർ ഇറ്റ് ഹീറ്റ് സ്ട്രോക്ക് ഓർ വെൻ വി ഡയഗ്നോസ് അല്ലെങ്കിൽ വേറൊരു ഡിസീസ് എന്ന് വെച്ചാൽ മാനേജ്മെന്റ് ഈസ് വെദർ ഇറ്റ് ഇസ് ബേൺസ് ആയാലും സ്ട്രോക്ക് ആയാലും ഫൈനലി വിറ്റ് എൻഡ് അപ്പ് വിത്ത് DIC ആൻഡ് കോയഗുലോപ്പതി. അപ്പൊ ആ മാനേജ്മെന്റ് വെദർ ഇറ്റ് ഇസ് ഡ്യൂ ടു ഹീറ്റ് സ്ട്രോക്ക്, വെദർ ഇറ്റ് ഇസ് സം അതർ എൽസ്, ഫൈനലി ദ ട്രീറ്റ്മെന്റ് ദ പേഷ്യന്റ് എൻറ്റർ ദ ICU, മാനേജ്മെന്റ് വിൽ ബി സപ്പോർട്ടീവ് ആൻഡ് ട്രീറ്റ്മെന്റ് ഓഫ് കോഴ്സ്. ഈ സ്ട്രോക്ക് ആണെങ്കിൽ ഇത് കൊടുക്കണം അത് കൊടുക്കണം എന്നുള്ളതിനകത്ത് യൂഷ്വലി അല്ലെങ്കിൽ ഡ്രഗ് ഓഫ് ചോയ്സ് എന്നുള്ള രീതിയിലേക്ക് ഇതിനകത്ത് ആസ് യൂഷ്വലി ഒന്നും പോകുന്നില്ല. അത്
അതിലെ പ്രോബ്ലം എന്താന്ന് പറഞ്ഞാൽ ഒരു പേഷ്യന്റ് 104 degree 105 degree വിത്ത് കൺവൾഷൻ വരുന്നു നമ്മുടെ OPD-യിൽ. And the first diagnosis will be that he is having a meningitis or I don't know, it's a diagnosis. Nobody is going to cool him. You understand? Nobody is going to cool him. Therefore, the primary thing is not going to be done unless you make a diagnosis of heat stroke. I always has to wonder. This absence of sweat is not that important. I don't know much about it, but up to date writes it very clearly. And many things happen because the moment the child field the ambulance patient definitely. Once you put cold water, you cannot measure the temperature later. It is been a sponge. But when the patient comes to you, the temperature will be normal. And you might think that it is something else. Therefore, the core temperature measurement is important. It's not the same management, because if it is heat stroke, you're concentrate on lowering the temperature. And if it is just a fever with a convulsion, you are thinking of something else. Issue the history is the most important thing by which you diagnose. They say it is the ambient temperature need not be that high. If suppose a patient has got a child has got a fever, for you and me, if the child has got a fever, he goes to school and he plays in the physical department. ആ സമയത്ത് ഒരു 45 മിനിറ്റ് കളിക്കുന്നു, heat exhaustion can വരാം, exercise വെച്ച് വരാം. But there must be an element of suspicion with us. There's no doubt about it.
Thank you, sir.
And children are more prone, mind you. Children are. And another thing is that നമുക്ക് തണുപ്പെന്ന് പറഞ്ഞാൽ നമുക്ക് സഹികെടാൻ പറ്റും, നമുക്കറിയാം സഹിക്കാൻ പറ്റുന്നില്ല, വിറയ്ക്കുന്നു. ഹീറ്റ് എക്സോഷൻ അങ്ങനെയല്ല. You go, you think you are okay, കുറച്ച് ദാഹം, കുറച്ചൊരു ക്ഷീണം, ടപക് ഒരടിയാണ്. The patient will fall down with this very fast, just like a heart attack or therefore that it is instantaneous that it comes, unlike the problems with when the temperature is cold. Many laborers will think I can do it. I have done it year after year. What heat stroke? പക്ഷേ ഒരേ ആൾക്കായിരിക്കും അന്ന് കാലത്ത് അയാൾക്ക് പനി വന്നു കാണും, അല്ലെങ്കിൽ 2 ദിവസം മുമ്പ് he would have taken some medicines which would have problematic for this. Then it immediately hits you.
Yeah, thank you so much, sir. That was very
Okay.
interesting.
Okay. Now I think Dr. Anand is here, so I request Dr. Anand to propose the vote of thanks. Dr. Anand.
ഒന്നും കേട്ടില്ല.
Dr. Anand.
He's connecting to audio. Hi, sir. Sir, enter. I think sir should call him. Sir, again. Actually.
Dr. Anand, please. Hello, Dr. Anand, can you hear me?
Hi, Kekamo, sir.
So, please propose the vote of thanks.
Kekamo.
Yeah, Kekam. Go ahead.
Hello, am I audible?
Yeah,
Am I audible?
you're audible. Yeah, fine.
Okay. Sorry, I had to leave in between because I had a call from the hospital.
Okay.
So
കേൾക്കുന്നില്ല.
Hello. Dr. Anand.
I think we can't hear him. Neither can we see him.
Anand sir, the mic mute ആണ്. Sir, connection issues ഉണ്ടെങ്കിൽ sir can go ahead. No, sir വന്നു. Anand sir.
Kekamo, sorry.
Yeah,
the connection issues. Thanks, Dr. Sir. Thank you for organizing yet another journal club. Sorry, I had to miss the case discussion in between. I would like to thank our speaker, Dr. VIDHUSREE as NAIR, for the case presentation, Dr. SAJITH DS for the discussion, and as always, Dr. Anju Kanmani and Sapnavan sir for chairing and coordinating the session. It is an immense pleasure trying to bring these meetings to you all. Keep tuned in for further sessions on the IMA group, and we will have more workshops and journal clubs and practice changing updates coming up. Thank you.
Thank you.
Thank you very much, sir. Thank you, Patnath sir.
Bye.
Thank you, Sajith sir. Thank you, VIDHUSREE madam. Thank you, Pradeep sir. Thank you all.
Good night.
Good night, sir.